Well, we mentioned hypothermia obviously is a life-threatening condition, so we need to learn what the complications of rewarming are and how to avoid them. And in a sense, we've already covered some of this. Now, one principle is we should try and keep these patients flat and not have them in a standing position. Some hypothermic patients have been rescued, for example, out of a cold sea in an upright position. Now, if you think about it, this means that the blood is going to tend to pool in the feet, and that is going to further reduce the already compromised venous return to the heart. It's going to lower venous return. And if you lower venous return, you're going to lower cardiac output. That means you're going to lower the perfusion of the myocardium itself. So quite a few patients have actually died, have actually gone into cardiac arrest due presumably to myocardial hypoperfusion, secondary to reduced cardiac output, secondary to reduced venous return, because they've been rescued in a standing position rather than a flat position. So keep these patients flat until they are fully recovered from the hypothermia. Patients are going to be hypovolemic and hypotensive because of vasodilation, because of the shift in the body fluids. We've already talked about that. So hypotension, persistent hypotension. Vasoconstriction increases the cardiac output demand. This means that when the patients are recovering, if there's a vasoconstriction, that's going to increase the peripheral resistance. If you increase the peripheral resistance, you increase the demand and the cardiac output. Because the heart is pumping against an increased resistance, you're increasing afterload of the heart. And again, because the heart is cold and irritable, probably acidotic, probably hypoxic, the heart is just generally insulted by lots of things. Again, any increase in demand could make ventricular fibrillation more likely. And actually, when you think about it, if a patient's standing up, that's going to increase demand as well. That's another reason to keep them flat. Afterdrop. Afterdrop means a reduction in temperature, in core temperature, after the patients have been rescued. So you might pick a patient out of cold water or out of a cold situation, and the temperature may be, say, 33 degrees centigrade. Then as you warm them up, the core temperature can actually drop 1 or 2 degrees centigrade. Cold blood can come back to the heart, and this can cause cardiac arrest. And the reason here is the cold blood returning from the periphery. This is why we mentioned that you shouldn't give patients warm cups of tea immediately after they've been rescued, or very hot. No, actually you can give them things that are warm, but not things that are hot, because it's going to increase the peripheral vasodilation of the veins and the arteries, and that's going to bring cold blood from the limbs back to the centre, and the core temperature is going to drop, the principle of afterdrop. Now, later complications of rewarming, well, we mentioned many causes of rewarming death already. And actually, whether you call these later or earlier complications doesn't matter too much. But the point I'm making here is that a patient can appear to have recovered and yet still die. A patient isn't really safe till they've been normothermic for some period of time. Now, in elderly patients, very often they become hypothermic because of some disease process. And when they're warmed up, this disease process becomes obvious again. For example, they may have had a stroke. So death can be caused by the disease which caused the hypothermia, as well as the hypothermia itself, if there is a pathological cause of the hypothermia, as you can often find in elderly patients. We've mentioned that the reversal of the cold, the reversal of the cold edema and the correcting of the cold-induced diuresis can lead to fluid overload. And fluid overload, as we've said, is going to increase venous return and increase demand on the heart, which can make the heart more irritable. But as well as that, of course, if you do get an increased central venous pressure, you're more likely to get pulmonary edema developing as well. So complications as a result of the reversal of the fluid shifts caused by the hypothermia. Toxins from the periphery, again I think we've mentioned that. Pancreatitis, another complication that can occur after hypothermia. Now what seems to happen here is that there's a vasoconstriction of the pancreas during the time that the patient is hypothermic. And the proenzymes which are made in the pancreas, of course, aren't actively proteolytic until they're activated in the lumen of the gastrointestinal tract. For example, let's see if I can remember some. Chymotrypsinogen is produced in the pancreas and isn't converted into chymotrypsin until it reaches the duodenum. But if there's vasoconstriction and there's no blood flow through the pancreas, what seems to happen is that these pre-enzymes or protoenzymes, for example the chymotrypsinogen, are left in the pancreas for a longer period of time and can be converted to the active proteolytic form of the enzyme. So the chymotrypsinogen will be converted into chymotrypsin. And of course, once you've got an active form of the proteolytic enzyme in the pancreas, it's actually going to start to digest the pancreas itself. Autodigestion of the pancreas is the essential nature of pancreatitis. So a very potentially serious complication that can occur once the patient has warmed up a bit. Another complication is rhabdomyolysis. Now, rhabdo, that means to do with the skeletal muscles. Myo means muscle, and lysis means to break up. So rhabdomyolysis means there is a breaking up of skeletal muscle cells. There is essentially death of skeletal muscle cells. And this means that myoglobin is released into the circulation. And the myoglobin, amongst other things, can block up the small channels between the capillaries of the glomerulus and Bowman's capsule, resulting in an renal failure from the rhabdomyolysis. There can also be hepatic damage. And really, I think we actually could include renal failure as a separate category. And the other one is bronchopneumonia. Bronchopneumonia we've mentioned really because the cilia aren't working properly, and you can get secretions accumulating in the lungs, fluid in the lungs. There's a possibility of pulmonary edema as well due to the increase in central venous pressure. But just the secretions accumulating in the lungs means any infection present is not going to be wafted out. You're going to get a pulmonary secretory stasis. There's not going to be the removal of the mucus. And any time you get mucus accumulating in the lungs, there's a risk of infection. And because this is all over, it's going to be a bronchopneumonia, it's going to be a diffuse pneumonia, as opposed to the lobar type of localized pneumonia.